for those of you who don't know me, I'm Katharine Lowndes. I'm a general haematologist. So I'm a consultant haematologist in the UK, but I look after a little bit of everything. And that includes the laboratory. I am not a laboratory expert in the same way as Yvonne is. I do a little bit of everything. So I prepared this talk originally actually for our laboratory, and it was really for the biomedical scientists, and it was as an introduction to white cells. So we did an introduction to red cells last year, and this was the accompanying one, which is an introductory to white cells. I apologize if it's really too basic for some of you, but it's good to start with this, and then we can do subsequent lectures or talks which are a little bit more complex if people are interested. So when I share my screen, I can't see anybody else. It all goes blank. So if anybody has any questions, by all means, just unmute yourself and ask, because I'm not very good at monitoring the chat. But when we get to the end, I can have a look at the chat if people have put questions in there instead. Fine, so I will just share my screen. So this is, as I said, just an introduction to morphology of white cells. And just by way of introduction, this is just, they're obviously schematogram of the of white cell production in the bone marrow and out into the blood. I'm going to be predominantly concentrating on the white cells that we see in the peripheral blood. So I'm not really talking about bone marrow pathology today. I think that's another talk all of its own right. I'm just going to concentrate on white cells within the peripheral blood. But if you go back to the bone marrow, you have your hematopoietic stem cell, which then differentiates into both myeloid and lymphoid, the lymphoid producing the lymphocytes, and then the myeloid producing everything else. So the basophils, eosinophils, the neutrophils and their precursors, the monocytes, and obviously the megakaryocytes and platelets, as well as the red cells. So what I want to concentrate on is these cells at the bottom. And this is one of those magical films where you can see most things all in one field, but these are the cells we're going to be talking about. So obviously we talked about the red cells or erythrocytes last time, the biconcave discs. I'm not really going to touch on platelets much today, but we're talking about the lymphocytes, the neutrophils, the multilobated granulocytes or neutrophils, basophils, said as such because they have these dark granules which are basophilic. They like base, they like alkaline stains, and then the eosinophils, which the granules are this red color because they take up the acid. And then you've got monocytes, which are larger cells. They're the largest cell that you can get in the normal peripheral blood, and often have this folded nucleus with quite often vacuolated cytoplasm. But I will go into it in a little bit more detail. So to start with the lymphocytes, these are the smallest of the white cells. And if you remember when we look back, if you're trying to decide on a blood film whether a red cell is large or small, whether it's what the size is, if you don't have an MCV or full blood count isn't working, then you look at the nucleus of the lymphocyte, and it is about the same size as a red cell. So they are small cells, normal condensed. The chromatin within the nucleus is clumped, it's condensed. So you get areas which are darker. It is not fine. And usually there's a small amount of pale basophilic or blue cytoplasm around the rim. And as I said, the nucleus is just very slightly larger than a normal red cell. But of course, there's quite a lot of variation in the sizes of lymphocytes. And this is just by way of explanation. On the top here, you've got these small lymphocytes. You can see the clumpy chromatin, and you can see the little rim of cytoplasm around the outside. But this is also a lymphocyte, and this is a large granular lymphocyte. It can be malignant, it can be reactive, but it's just by way of the fact that actually lymphocytes can change in their appearance quite considerably, and you can get quite a lot of variation. But usually, yep, the lymphocytes are small, they're heavily stained condensed nucleus with the cytoplasm, whereas the large granular lymphocytes, they often have these clear granules in the cytoplasm, and can be upwards in 2 to 3 times the size of the red cells, so quite a lot bigger than these little small mature lymphocytes. There's quite a lot of background noise. If others are able to mute, that would be helpful. Thank you. So just to some of the other cells that you see, these monocytes here with the irregular nucleus, and the difference for them is that their cytoplasm is sort of blue-grey and often vacuolated. Now, metamyelocytes you don't see terribly often in the peripheral blood. You do occasionally, and I'll come on to that as to why you might see them. And they can sometimes have a slight indentation in the nucleus, and sometimes described as being kidney bean shaped. But they do tend to have a more granular cytoplasm, and a cytoplasm which is much more similar to either a band form or a neutrophil rather than a lymphocyte, which tends to be more basophilic. So I just wanted to show you some pictures of lymphocytes which are actually reactive. So they're normal lymphocytes doing what lymphocytes do. And that's reacting most commonly to infections, but commonly viral infections. And as you all know, the other name for Epstein-Barr virus is also infectious mononucleosis. And the reason it's called infectious mononucleosis is because when you look at it down the microscope, the lymphocytes can look pretty wild. And the key is that quite often the cytoplasm is around, is abutting the edge of the red cells and is scalloping around them. And this is often what we see in patients that have got nasty viral infections. But this is a normal reactive lymphocyte. But of course, reactive lymphocytes can vary in themselves. And the important thing to note is that if you look down the microscope and you've got lots, the lymphocytes are all looking slightly different. So we would describe that as being pleomorphic. They're not all monomorphic. They're not all exactly the same, but there's a variety. You've got some small, some medium, some large. That is much more a feature of a reactive process. So something that is reacting to commonly infection. They often, the larger ones have got obviously more abundant cytoplasm, but it's often very blue. And you can sometimes see nucleoli, which is things that we often associate with blasts or more pathological cells, but you can certainly see this in a reactive lymphocyte. And I think it's what I was always taught is that you never look at an individual cell in its own right. You always look at the company that it keeps. So you look to see what the general picture is with all the lymphocytes. The other thing is that some of them can end up having this little pale area around the nucleus, and then this dark blue cytoplasm. And that can look a little bit like a plasma cell, which I'll come on to later, and we can describe those as being plasmacytoid. But if you get a mixture of all of these cells, this is much more in keeping with a reaction to infection. So then just talking about the neutrophils. And if you remember when the scheme right at the beginning, I'm sorry about the color of these. They obviously hasn't translated very well. They look like very, very old blood films, but they are pictures, so it shouldn't have changed. But anyway, we're going to, if you go back to the diagram that I mentioned at the beginning, we're looking at the neutrophils, but then the neutrophil precursors. And this is just the range of all of those cells. And in some situations, you can see them in peripheral blood if patients are really sick. But generally speaking, if you see any of them to excess, then it is pathological. So we'll start the more immature forms, and these are blasts. So they tend to have a very large nucleus. They have fine granular cytoplasm, so it isn't dense with not cytoplasm, sorry, nucleus. It isn't dense with the chromatin clumped. It tends to be finer. People talk about it being just shaded in with a pencil. And then these little nucleoli here, which would be another marker that they are immature. The cytoplasm is usually not that great, and it is also quite often doesn't have any granules in it at all. So that would be a normal blast. Obviously, there's a variation that you will see from when we're looking at leukemias, but we'll come on to that. That then matures into the promyelocyte, which the nucleus tends to become a little bit more round. It moves a little bit towards the side of the cell, and the granules become much more dense and much more purple. These promyelocytes can often be larger than the blasts, so these are often quite considerable size and do stand out. This then, when maturing further, there are two things that are ending up maturing. You get the nucleus, which is maturing, but then also the cytoplasm, which is maturing as well. And in the myelocyte, you will get the nucleus tends to become denser. It is a little bit more round. The chromatin starts to become a little bit more clumped, and you very rarely see a nucleolus in the myelocyte. The granules then also mature, and if you look at the back of the cytoplasm here, it's starting to look a little bit more like the cytoplasm that you would see in a neutrophil. This then progresses to a metamyelocyte, where often the nucleus is again described as being kidney bean shaped or starts to get an indentation. It then starts to clump more. You get clear lobes of the nucleus developing. But the links between the lobes of the nucleus are quite thick, and then moving to the neutrophil, you have thin strands of chromatin which are linking the lobes of the neutrophil. With regards to the neutrophil, normal is up to 5 lobes. Beyond, you can have 1 or 2, which is more than 5 lobes, but if you've got any more than that, we start talking about hypersegmented neutrophils. The cytoplasm becomes more pink with fine blue granules, as opposed to the dense blue granules that you have in the more immature forms. So, just by way of illustration of what I was talking about with regards to the neutrophils, normal is about 5 lobes, but here we've got 1, 2, 3, 4, 5, 6, probably 7 lobes, depending on the orientation that you've got there. And that would be described as a hypersegmented neutrophil. Now, that is fairly classic in a megaloblastic anemia, so in patients that have got B12 or folate deficiency, but you can see it also in conditions like myelodysplasia. So it is not completely pathognomonic of B12 or folate deficiency, but it's certainly, you need to make sure that they are replete, because you should not be diagnosing somebody with myelodysplasia unless you know that their B12 and folate are normal. The other side of it here is where you actually don't have very many lobes at all. In fact, these are just 2 lobes with a very thin strand of chromatin in between them. And this is what we would describe as the pseudo-Pelger-Huet anomaly. And that is what we would see in myelodysplasia. The reason the other description that it's been given is the pince-nez, which is these glasses that that people used to have, where they didn't fold around their ears, they just pinched the top of their nose, and so you would end up with two glasses and a tiny little rim across the top, but more commonly known as the pseudo-Pelger-Huet anomaly. Now it has frozen. It's not going forward. Try that. Okay. So that was talking about the nucleus of neutrophils. Now I just want to talk about the granules in the neutrophils, so that when you're looking at them, you can look at those two things separately. So in here we've got a number of different granular appearances, and in this one here you've got very dark granules. Now, generally speaking, the granules in neutrophils, it hasn't projected terribly well here because they look mainly pink, but they tend to be pinky blue. And when they're very coarse, excuse me, I'm going to sneeze. When they're very coarse and lots of them like this, we often describe it as being toxic or toxic granulation, because we see that in a lot of infections. So if you see lots of granules like this, it's often that the neutrophil is doing what it should do, is being reactive. But these really, and I'm assuming that you can all see my pointer, and somebody, Yvonne or somebody, tell me if you can't see my pointer, but
yes, we can.
Here, yep. You can. Oh, fantastic. There's a much bigger looking granule on the side here next to the arrow, and this is actually a Dolly body, and we see that in classically in infections, but you can also see it in burns. You can see it sometimes in myelodysplasia. You can also see it in pregnancy. And it's actually made up of rough endoplasmic reticulum with ribosomes bound to it. So it can be present in other situations, but that's the Dolly bodies here and here, as compared to in the other side, which is this is an inherited condition called Chediak-Higashi syndrome, and these have got giant neutrophil granules, which are quite different to these. So the ones on this side are all fairly small, but lots of them. Here, they're much bigger and not quite as uniform. And this would be a situation where it would be an inherited condition as opposed to a more reactive condition here. Often when you are talking about or describing a blood film in a patient, you often use different terms, and we mentioned about toxic granulation in the previous slide, but that often goes together with a condition called left shift. And when we talk about left shift, we're really just saying that we can see immature myeloid cells within the peripheral blood. And so that's your normal segmented neutrophil, but you may well see band forms. You may see metamyelocytes, and in some situations in severe infection or leukemoid reactions, you can see myelocytes as well, which is not as common, but in the context of somebody who's very unwell with infection, may well represent a reactive response. So we've talked about reactive lymphocytes, which can be quite varied and can look quite wild. This is the reactive version of neutrophils or myeloid cells, which you can also see in the normal peripheral blood. And then just going on to the other white cells, you've got your eosinophils, and as I mentioned before, they are named as such because they are eosin, they're philic of eosin, they like acid, so that's why they have red granules as opposed to the basophils, which have these very dark purple granules. And then the monocytes, which are much bigger, they are the largest cells in the peripheral blood, and they often have these vacuoles, they have a folded nucleus, and they have this pale grey-blue cytoplasm. Just to mention, the eosinophils should be less than 5% of the white cells. Often the nucleus is bilobed, And you would see an increase of these in parasitic infections, in allergy, and in some autoimmune conditions as well. You can see them in some hematological malignancies, particularly Hodgkin's lymphoma. The basophils are much less frequent. They're usually less than 1% of the white cells, and they are much more associated with myeloproliferative disorders such as CML, and you can get other basophilic forms of rare mast cell problems and leukemias as well. Okay, so I'm just going to just do a series of cases really and use that to try and illustrate some of the things we see with regards to white cells in the peripheral blood. And I've concentrated on the sort of commonest or the more important ones, but obviously there's lots that I won't have covered. So for the first case, I've got a 46-year-old woman with a fever and fatigue and a white cell count of 46. Now, I don't know if, I'm just going to see if I can see here. I don't know if anybody wants to tell me what they think is going on here, and it's not difficult. So anybody, feel free to shout out if you would like to tell me what you think this might be. I'm not sure that anybody feels they want to say anything. Okay, well, you've probably all got it. Oh, it's not forwarding. So this is acute myeloid leukemia. And so apologies, I'm just going to, that's it. And the reason for that is that you've got lots of these blasts. It doesn't project terribly well. It's a little bit faint, but if you're going, may have to take my word for it. They have these, well, to start off with, they're white cells. They all look the same. They are not varied. And they don't look like cells that you would normally see in the peripheral blood. So that's never a good sign. They have a large nucleus. They have this fine chromatin. So if you imagine you were filling this in as with a plain pencil, it's generally fine with these nucleoli in the middle. And some of them have got 2 nucleoli, and you get the impression with this one that the nucleus might be slightly folded. So what we look at for blasts is to look at the nucleus. We look at the cytoplasm, and a key indicator of acute myeloid leukemia would be these things called Auer rods, but they're not always there, and it can often be, they can be completely agranular, so have no granules. By way of illustration, and I'm hoping that this projects, these Auer rods that I was talking about are these thin purple, reddish purple lines. They're actually fused primary granules. But if you see those in the cytoplasm of a blast, then it is pathognomonic of AML. Now, by contrast to that, this is a 20-year-old man who's presented with a low-grade fever and just feeling generally tired. When you examined him, he's got bruises or purpura all over him, and on his blood count, he's got a slightly raised white count, but his platelets are definitely low. Interesting, in this situation, his PT and his APTT are normal, but his D-dimer is significantly elevated. And what you've got here are lots of cells that look very similar again, some of them with nucleoli. So you would be correct in thinking that these were blasts. But what you have got in these is a lot of these Auer rods. And this is a picture of a patient with acute promyelocytic leukemia. And the reason that this is really important to be able to pick up is that if you can, the main problem with these patients is that if these cells break down and these granules are released into the circulation, they end up with DIC and become very sick very quickly and bleed. So what you want to do is get them onto ATRA quickly. So it's really important that you can recognize this and you can alert people to that. There are obviously variants that come with this, so not all of them have got those classic cells with lots and lots of hour rods. And in the ones that are variants, you tend to see that the nucleus is bilobed. So if you end up with lots of blasts, but the nucleus being bilobed like this, then you also need to think about the possibility that this might be a PML. Now, acute myeloid leukemia has had over the years many different classification schemes, and what myself and Yvonne will have grown up with is the FAB classification, and that's the French American British classification, which actually dates back to the 1970s, so it's pretty old. And it was really just classifying the leukemia depending on what you could see down the microscope. And it was M0 to M7. And we all spent ages clustered around microscopes trying to decide what type of leukemia it was. But of course, now the classification of leukemia has changed quite considerably, and it is mainly around the genetic abnormalities that you will find. And the important thing is that if you have had a previous exposure to cytotoxic chemotherapy, then you have your own category of leukemia, and that's important because it's treated differently. Ideally, if you have access to the genetic testing, you then subclassify your leukemias into leukemia with that particular genetic rearrangement. There is a separate category for patients that have developed acute leukemia on a background of previously having had myelodysplasia. And then there are other separate genetic abnormalities. But in your setting and in a lot of slightly more low resource settings, it's not possible to access all of this genetic data. And so the AML defined by differentiation, or what you can see down the microscope, is still very valid. And it is important they are historically associated with differences in prognosis. And so it is part of the hierarchy of how you would classify acute myeloid leukemia. It's not exactly the same as the FAB classification, but they've basically classified it into AML with minimal differentiation, without maturation, and then with maturation, and then they've gone for basophilic, myelomonocytic, monocytic erythroid, and megakaryocytic, so megakaryoblastix. So it is still important that we can try and discern those down the microscope. And within the criteria, it tells you exactly how you classify those, the leukemia, dependent on what you can see down the microscope. Ideally as well with the application of flow cytometry, because that will help. And the number of times you think you see something down the microscope and then you send it for flow and it comes back as something slightly different, is more times than I care to mention. So I think flow is really very helpful in trying to discern these things. But ultimately, you need to have more than 20% blasts in the bone marrow and or the blood, except for with acute erythroid leukemia, when it's more than 30%. You use this when you either don't have access to the genetics or you don't have any genetic aberrations found if you're able to access the genetics. You haven't previously had cytotoxic chemotherapy, and you've got no prior history of either myelodysplasia or myeloproliferative neoplasm, then you would use this classification to try and discern which type of AML it is. If we then look at ALL, acute lymphoblastic leukemia, then again, they do look slightly different. They have, again, the same large nucleus with pale blue cytoplasm. Often there's less cytoplasm and very few granules, but you can get caught out. The one thing that does tend to be more of a sign is this thing called the hand mirror appearance. And this is where you get blasts that have a protrusion of the cytoplasm out, supposedly looking like a hand mirror. And you can tell that, obviously that was named as such many years ago when hand mirrors were something that anybody used. Okay, so on to something slightly different. Case 3 is a 55-year-old man who presented feeling just generally fatigued, but also feeling particularly full after very small meals. He's slightly anemic with a hemoglobin of 105, but he's got a white cell count of 125, so really quite high, and a normal platelet count. And when you have a look at the blood film, you can see that, in fact, looking down the microscope, everything looks slightly different. So it's not all looking the same. This doesn't look like acute leukemia with lots of blasts that all look the same. But if you look down, actually, most of the things you see down the microscope are of myeloid origin, but there's lots of variation. So you've got lots of neutrophils, but you've also got band forms. You've got the metamyelocytes and some myelocytes here. You've even got probably a promyelocyte, but you're going to have to take my word for it that some of these have got quite, this has got basophilic granules in it. This one here is actually a basophil. I can see it clearly on my screen, but it may not be projecting terribly well. It's got very dark staining granules. And this is a film which shows chronic myeloid leukemia. So what you would tend to see in this setting is you'd get granulocytosis at all stages of maturation. Quite often there's an increase in the basophils, and the myelocytes tend to be more prominent than the metamyelocytes. Then another case, we've got a 77-year-old woman with fatigue and night sweats, and on her blood count, she's got a white cell count of 65. And if you just look at the film, the cells, I'm sorry, it's a little bit hazy, it's not projecting terribly well, but the cells are small to medium sized, not very much cytoplasm, a little bit of cytoplasm around the edge. The chromatin is clumped, and if you remember back, this does have features. These are features of small mature lymphocytes. For those that are going for the gold star in the room, you've got these cells which are slightly disrupted, or we call those smear cells. And the combination of this is has a very particular sign, which is in keeping with chronic lymphocytic leukemia. So what I would say here is that they have small cells, the mature chromatin, which is clumped, little in the way of the cytoplasm, and classically for CLL, it's said to cover up to 2/3 of the outside of the nucleus, but it's not usually around the whole nucleus. And then these smear cells. But then people who are really observant will notice something else in this particular film, and that is that you have got a nucleated red cell, which we do not see terribly often in the peripheral blood. And you've also got these little dense, dark, round red cells. So these are spherocytes. And it looks like that there are signs here that this patient is hemolyzing. And we see this not uncommonly with CLL, which can trigger the hemolysis. Okay, so I'm going to have to speed up. I'm going a bit slow. I'm sorry about that. This is just for interest as well. This is a 64-year-old gentleman who was found to have pancytopenia and an enlarged spleen. And what I want you to pick up from here is that we've got cells with a round nucleus with clumped chromatin or bunched up chromatin, which means they are mature. But if you look at the cytoplasm, it looks a bit ragged. It's got these projections outside, and you could describe these cells as being hairy. and or having villous projections, and indeed this is inconsistent with hairy cell leukemia, and these cells are lymphocytes. It's a mature lymphocytes, and it often presents fairly indolently in the sense that they've been developing their enlarged spleen for some time. The cells classically have a pale blue cytoplasm. They have these irregular projections with the cytoplasm, and there are variations. So normally you have the nucleus, which is at the in the middle, but you can get some that are variants which don't have so much in the way of projections, and the nucleus is very much to one side. Good. So the next case is a 56-year-old lady who presented with fever and night sweats, and when on examination had widespread lymphadenopathy. And if you saw these circulating in her blood, they are, again, these are small, mature lymphocytes, but there is an indentation here in the nucleus. And on this one, it's on both sides, but this is much more in keeping with a follicular lymphoma. You don't see this terribly often in the peripheral blood, but you certainly can. The key here is that they've got very, very little in the way of cytoplasm, and often you can only just see the cytoplasm at the area where there is a cleft in the nucleus. But one to look out for. And again, I would never fixate on just seeing one of these cells in the peripheral blood. So it's more about how much you see, because if you look hard enough, you will find odd cells when you're looking at peripheral blood. But what you want to do is pick when there are lots of cells that all look the same. And then the next case is of a 61-year-old lady who presented with back pain. When you do her blood count, she's got a hemoglobin of 9, so she's significantly anemic. She's got renal failure with a creatinine of 274, and her calcium is also up. And if you see these cells circulating in her blood, it's helpful from a diagnostic perspective, but it's not great news for her because these are plasma cells, and the majority of time you do not see them circulating in the blood. Now, you can see them in the cases of myeloma when patients have got it very advanced disease or very high burden of disease with 1 or 2 cells spilling into the peripheral blood. But if you see many more of them, then you're looking at a plasma cell leukemia, and the outlook for patients with plasma cell leukemia is very poor. But often these cells are described as looking like a fried egg. Quite often the nucleus is to one side. You have this characteristic pale area or HOF around the nucleus, and the cytoplasm is very basophilic. But they stand out. When you're looking at a blood film, they do sort of shout out at you because they look very different to anything else that you would normally see. Okay. I'm feeling this might be my last case, but this case is a 60-year-old man with back pain and pancytopenia. And this is quite different to the one that we saw before. So we don't have the plasma cells circulating, but what you've got here is a range of things that you shouldn't normally see. So you do have immature myeloid cells. So sometimes promyelocytes, this is a myelocyte or blast. You've got a nucleated red cell, so you've got immature red cells. And actually, with the eye of faith, you've got a teardrop-shaped cell here. And so the combination of immature white cells, immature red cells, and plus or minus the teardrop red cells is what we would describe as being a leukoerythroblastic film. So you've got leucoblasts and you've got erythroblasts. So young, immature white cells, young, immature red cells, all in the peripheral blood at the same time. And you shouldn't have that. If you get that combination with the teardrop red cells as well, it suggests that the marrow is struggling. So the marrow is either struggling because it is full of something that shouldn't be there. So metastatic cancer is one of the causes, or there's scar tissue, there's fibrosis in the bone marrow. The only thing I would say about that is just be careful about patients that had had GCSF or growth factors to try and support them through their chemotherapy, because they can, the growth factor causes their bone marrow to push out lots of immature cells, whatever the bone marrow has got. And so sometimes you can be fooled into thinking that something really nasty is going on. But if they haven't had GCSF and you see a picture like this, you must be worried that something is going on from a bone marrow perspective. So it's 1:45. I'm happy to take questions. I've got one or two rare cases which I can show you just for interest if you're interested, or I can stop there and take questions depending on what you would like.
Dr. Sahar, what would you like?
I think you can proceed for the other two cases.
Okay, that's fine. Great.
Katharine, before you start, can I just check? There is everyone, please notice in the chat, there is a link. If you click on the link and fill in the feedback form, then that will enable us to have your email addresses, and we will be able to send you a link of the recording of the talk, which will be available, I think, for 2 weeks. Thanks, Katharine.
No worries. Great. Okay, so I haven't. This is you'll recognize the photograph from before on this one. So this is we sometimes see these patients. This is a 33-year-old lady with rheumatoid arthritis who developed oral ulcers, and on further testing was shown to have a very low neutrophil count, and then on her peripheral blood had a lot of these cells, and she ended up having large granular lymphocytosis, or a large granular lymphocytic leukemia. Now, this is quite common in association with rheumatological disorders, and it doesn't always require any treatment, but some of these patients can end up with significant lymphadenopathy, and the treatment for them often is immunosuppression as opposed to necessarily chemotherapy. So often they end up getting treated with methotrexate, and so sometimes their treatment of their rheumatoid arthritis actually controls this. But it's one thing to look out for if you've got patients with rheumatological disorders who then become cytopenic, particularly neutropenia. This one is you may well see more commonly than we do. It's a 22-year-old lady with a 2-week history of fever and anemia with marked lymphadenopathy, hepatosplenomegaly, and skin rashes. And these are classically described as being flower cells, where the nucleus is looks like a flower, and is associated particularly with HTLV infections. So this is adult T-cell leukemia lymphoma. Again, quite difficult to treat, but if you see it under the microscope is quite striking. And then by way of comparison, and I would say that the film I've got for this is not terribly good actually, but this is a cutaneous T-cell lymphoma, and you can see Sézary cells occasionally in the circulation with these patients. Now, Sézary cells are the nucleus is described as being cerebriform, or looking like a brain. I would argue, and you would be right if you were thinking the same, that this doesn't look that dissimilar to the ones that we saw in the previous one. but maybe less flower-like, maybe more brain-like. I'll leave that to you to decide. But I mean, the key in these are T cells, and they're pretty wild looking. So again, if you see one of these, it's often irrelevant, or it may well be due to the slide preparation. But if you're seeing lots of them, then it suggests there's something else. But quite often with these patients with cutaneous T-cell lymphoma, they often have very marked skin involvement with rashes or patches, or they can be diffusely erythrodermic, so that they have skin involvement throughout. So I think that's it. Yes, so that's the end of my talk.